How my journey started in terms of global oncology was that in my city, there's a local foundation called the John James Foundation. They'd actually been funding a number of surgical missions to the Pacific Islands as part of a volunteer specialist program. The other key is actually selecting who you work with, who are the collaborators. The people that I've been lucky to be able to work with have been very engaged and being responsive. You think you're going to achieve a target, you don't give up at the slightest barrier. And the superintendent at the time asked me if I could take on one of the medical registrars and help train him to be the nation's first medical oncologist. Going through that now, many years down the track, we've been able to achieve the majority of the recommendations that we've made in the areas of what they wanted from us, their needs, and also, my original recommendations.
Hello again. Welcome back to OncoDaily. Today on World Health Voices, it's a great pleasure to welcome Professor Desmond Yip from Australia, very well-known and accomplished clinical oncologist with a narrow specialization on gastrointestinal tumors. But Professor Yip also has a lot done in the Pacific Islands to improve the quality care, cancer care in those islands, and to bring the cancer care to the underserved populations. Thank you very much, Desmond, for having a time for this discussion.
Thank you for having me. It's been a pleasure to be asked to speak on my work, my career.
Thanks a lot. I want to start from the beginning of your career. Why did you decide to become an oncologist, and a doctor, and then an oncologist?
So I went through medical school in the 80s and did my training in the early days of medical oncology in the early 90s. At that time, medical oncology wasn't a very popular specialty because we didn't actually have much in the way of drugs available to us. When I went through medical school, pharmacology was actually my favorite topic, so therapeutics and use of drugs, and it was also the subject that I excelled in. So I decided to pursue medical oncology, even though it wasn't very popular at that time because a lot of patients would pass away and there wasn't a wide range of drugs that we used, that we could use at the time. And the time that I started working was a big period in terms of drug development, and new drugs came through all the time. So when we first started treating patients, they would get rather sick because we just had metoclopramide and prochlorperazine as antiemetics, and then the 5-HT3 antagonists came through, made treatment of cancers a lot easier, and then there were new drugs that developed. So this is all in the days before targeted therapies and immune therapies came through. And we were lucky to be involved in clinical trials. So the people that I worked with in those days had an interest in clinical trials, and also some of them were translational researchers. And we were seeing new drugs coming through. And I took on GI oncology as an interest because that was an area which a couple of my bosses had said, nobody was interested in that either because there's only one drug available at that time. But those 5-fluorouracil, we used it for all the GI cancers. But there were new drugs which they could see were showing promise in the clinical trials, and became an area that I was able to continue. When I first qualified as an oncologist, I was a general oncologist because we were quite short. There was only 3 medical oncologists in my city, so we had to do everything. So I was trained as a general oncologist. But over the years, I've been able to progressively narrow down the tumor types and just focus on the ones that I had interest in, and now just in GI oncology.
When you began, as you mentioned, the arsenal you had was very small. Now it's very big.
Yes.
And you are working at so I want our discussion to be on two parallel sides because I mean you are I mean certainly throughout your career you are shaping the cancer care both in high income countries and also low middle income countries. So I mean the treatment arsenal and the diagnostic arsenal changed a lot in your clinic in Canberra, right?
Yes.
But you are seeing also the other reality in let's say where you work. You do a lot of global health work in Solomon Islands, I know,
Yeah.
and in other Pacific Islands. So first of all, why did you decide to go? I mean, anyway, you are already doing a noble work. You are an oncologist, you are treating cancer patients, you have a tough work, and you do science. Why did you decide, first of all, to dedicate also your career to the underserved populations, but also like you are seeing this progress in high income countries, but in the other context, you see like a different reality. How do you feel about this and how you are addressing this?
How my journey started in terms of global oncology was that in my city, there's a local foundation called the John James Foundation. They'd actually been funding a number of surgical missions to the Pacific Islands as part of a volunteer specialist program. So they were doing surgeries in the islands that were not otherwise, being done because they didn't have the skills to do that. But there was a request by the medical superintendent at the National Referral Hospital of the Solomon Islands to review some of the cancer protocols that they had in their hospital. And I thought, I can do that. That's something that wouldn't take too much of my time to go over. So I went over with a gynecological surgical team back in 2016 to have a look at what they had there. And they had some borrowed protocols that had come from the Children's Hospital in Melbourne and other places such as Papua New Guinea. But the cancer care there wasn't actually very well coordinated because it would be different teams and different doctors, coming out of theatres or between ward rounds, going to the surgical dressing room of the wards to administer chemotherapy to the patients after mixing it up themselves. And the role of the pharmacist there was just to dispense the vials of the cytotoxics. So I made some recommendations at that point in time, about what they could do to improve their cancer services and how to set up a proper chemotherapy unit. And the superintendent at the time asked me if I could take on one of the medical registrars and help train him to be the nation's first medical oncologist, and also two of the nurses who were actually involved in running the cancer registry with this doctor, to be their cancer nurses. And so, my involvement kind of stemmed from then. I took it on also because I had also worked in the early days of oncology where we didn't have that many drugs available to us. And the protocols that we had were quite simple. And, in terms of adjuvant treatment, when I was starting my training, we were just doing it for breast cancer. And so we had, simple protocols that we're using with not a very wide range of drugs. And I had that knowledge of how we did things in the old days and, with just metoclopramide and prochlorperazine. And, I thought I could, pass on that knowledge because a lot of our trainees now would not have that knowledge of how, simple things were in those days. Be using the best treatments, available to them in treating the different sorts of cancers, multiple lines of therapy, targeted agents, molecular guided therapies. And so I wanted to pass on that knowledge before I retired.
Desmond, who are your mentors?
My mentors over the years, those people who looked after me, my primary mentor would have been Peter Harper. He's a esteemed oncologist. He was a general oncologist who did almost everything, but he was an expert in each of the areas that he treated cancers in. So he was considered national, international expert in those areas. He ran a very busy Harley Street practice, as well as being the director of medical oncology at Guy's Hospital in London. I was his fellow for 3 years, and he looked after us very well and gave us very good, solid training in the art of oncology and running clinical trials, and also management skills and how to run multiple projects at the same time. I also had other doctors who looked after me. They were mainly GI oncologists, and that was Professor Stephen Clark, who's a GI medical oncologist at Royal North Shore Hospital in Sydney. Professor John Zalkberg, the GI oncologist at the Monash Hospital in Monash and the Alfred Hospital in Melbourne. Professor Stephen Clark, so I've mentioned him already, sorry.
No problem.
Pause. Yep. Professor Mike Finlay, who was also a GI oncologist. He worked at Prince Alfred Hospital, but later went to New Zealand. He's now retired. And Professor David Goldstein at Prince of Wales Hospital in Sydney. These doctors were collaborators and gave me many opportunities when I was a junior consultant. And we've worked on various projects over the years, and they've really helped to mentor me and to guide me in GI oncology.
What about your mentees? Who are your mentees?
There are many mentees, many registrars who are very glad to see me when I meet them at meetings, and they've achieved a lot. And I'm always pleased to see, how they've ended up, being their specialty lead in their units or achieved their academic promotion. The one I'm probably proud of the most is Andrew Soma, who's the doctor I've guided to be the medical oncologist in the Solomon Islands. From him being a medical registrar to being qualified as a medical oncologist, having got his Master of Cancer Sciences through University of Melbourne, and now being head of the department in the National Referral Hospital Oncology Unit. So starting from those days when it was just him and the 2 nurses, he's now got 4 registrars, which is more than the number of registrars I've got in my unit.
Yeah.
And 7 full-time nurses working in the unit.
So I'm going to ask a question. What is key to your personal success? And also, what is your key to success in global oncology?
The key to my success, I guess, in terms of my career progression and the projects and models of care I've been able to progress, is actually being able to multitask, to be able to handle multiple projects at the same time, and to also be able to track, what's happening in each of those areas. The other key is actually selecting who you work with, who are the collaborators. The people that I've been lucky to be able to work with have been very engaged and being responsive. And so being able to maintain long-term collaborations is developing that trust and being able to respond quickly to, email trails and to get back quickly with decisions to be able to move things forward. That often has to happen with being able to deal with less sleep, to be able to, make sure that your clinical responsibilities are taken care of, and that you can also fulfill, the other responsibilities of things that you've taken on. The work in the islands has also been the same, because the original work in the Solomon Islands is the same people who we've been working with right from the beginning over the last 10 years, and they've been very engaged. We started off with the recommendations that I made, as well as a needs analysis that I did with them from their point of view of what they wanted from us. And going through that now, many years down the track, we've been able to achieve the majority of the recommendations that we've made in the areas of what they wanted from us, their needs, and also, my original recommendations. So it's having that engagement and ongoing trust and collaboration has been the success for what we've been doing in that nation.
What would be your advice to a younger generation of oncologists who want to accomplish in oncology? What would be your advice?
I just think I'd say it, and don't think it's all too hard. You know, if you take on the challenge and you're committed and you think you've got the skills, you'll succeed. But you just have to be persistent. So the other thing I didn't mention was persistence, right? Yeah. You think you're going to achieve a target, you don't give up at the slightest barrier. You look for ways to get above or around a barrier, not try and go through it if you're hitting your head against a brick wall, right? So that's one of the management skills I learned over the years. Yeah, and that may come with mentorship. Yeah, often the juniors will come to me with a problem. I ask them if they can think how to sort it out, but they often may not see a way around it. But if you're experienced, you can guide them on how to overcome barriers. Yeah. So I think if they got a dream, they should pursue it.
You are seeing the disparities during your professional work, working into different realities.
Yes.
I mean, what would be your wish, or like if you come up to one solution, not to every problem, but not as one kind of size fit all, but like what the first thing you would do if you were in charge of the global changes or like global health organizations? What would be your first move? What you would do?
As a medical oncologist, you have to know what you're treating. You have to know the diagnosis. And I think the first step in any nation building cancer services is to be able to sort out accurate pathological diagnosis. So this includes basic histopathology, but also for a common tumor type like breast cancer, being able to determine the receptor status of the tumor to guide management. So knowing ER, PR, and also HER2 status. Breast cancer is such a common problem, and you can make such a big difference with the drugs that's available to treat it. And now trastuzumab is generic and has become affordable for a lot of these nations, but you have to have accurate pathology. And I think more resources have to be done in terms of developing those services in each of these nations. The next thing, I guess, is a drug supply, and that's another issue, I guess. There is a Max Foundation, it's a
Wonderful
Swiss-based
foundation.
organization, yes, who are supplying aromatase inhibitors and CDK4/6 inhibitors for breast cancer in the nations, also supplying other targeted agents to treat and even cure chronic myeloid leukemia. They've got drugs that can treat metastatic kidney cancer and also certain molecular subtypes of lung cancer. But it's important to have that sort of diagnostic capacity to guide the use of some of these drugs. Yeah.
This is a miracle
That
story. I
foundation.
agree with you. The
Yeah.
the Max Foundation. I was interviewing 2 days ago Pat Garcia Gonzalez, the president of the Max Foundation, and really the work they started with Glivec, and then now they are expanding. It's really
Yes.
amazing, and I wish we could have these mechanisms for many other things, really. And I'm on the same page with you.
Yeah. So one of the interesting things that Max Foundation are exploring is how they can get by that lack of immunohistochemistry in these Pacific Island nations. Because the problem is the access to the machines that do the slide staining, and also the technologists or technicians who can prepare the samples, and also the access to the reagents for the immunohistochemistry. But gene expert machines are everywhere in the islands because of the use in infectious diseases. They were rolled out during the COVID pandemic for rapid PCR testing for COVID diagnosis, and also for HPV testing now as part of the Elimination Partnership in the Indo-Pacific program. But there is a cartridge called the Strat4 cartridge. It's a gene cartridge, a gene PCR cartridge that you can put into the machine, and you get a ER/PR HER2 receptor back in 2 hours by just scraping some tumor onto the cartridge without the need for extensive specimen preparation. So the Max Foundation looking at that to see where that would overcome those issues in the islands, because they're supplying the drugs, to help treat breast cancer patients, but they need to know the receptor status of the patients with breast cancer.
Thank you so much, Desmond. And I want to ask you but before asking my last question, I'm going to ask one more question. Is there any book which made a big impression on you and that you would recommend everyone to read?
Emperor of All Maladies, if you're a cancer physician. Yeah.
Yes. Wonderful, wonderful book. I agree.
Yep.
I agree. I love it as well.
Yes.
And the last question I always ask, who I should interview next?
I think you should interview Professor Karen Canfield from the University of Sydney. I know you had an interview with our former Health Minister, Greg Hunt, about the cervical cancer elimination of Australia.
Yes.
But all the modeling
It was a
work,
great interview.
Yeah. All the modeling work was done by her. She's a cancer epidemiologist. And that informed
I know her.
Yep,
Yeah.
excellent. WHO Global Cervical Cancer Elimination Initiative was put forward by Australia. And I think Australia is on track to eliminate cervical cancer by 2035. But she also heads the Elimination Partnership in the Indo-Pacific for cervical cancer. So that federal government initiative with collaborations by the Kirby Institute, various foundations, including the Minderoo Foundation, the Fraser Family Foundation, has helped to roll out cancer elimination strategies in our Pacific neighbours. Very inspiring woman. I think you should interview her next.
I agree. I love that idea. But thank you so much, Desmond. It was a great pleasure. Thank you very much for this inspiring interview.
Thank you.
Don't forget to like, comment, share, and subscribe to OncoDaily on YouTube. Hit the bell icon to stay updated.